So Santiago Delgado is the Deputy General Manager of the Ribera Salud Group, which is the Alzira model, is part of an operator, amongst other things, of the Alzira model that you just heard about, and we're going to hear from him about their long journey to a very interesting model.
Okay. Thank you. Thank you to Imperial College Health Partners for your invitation to share with you our experience of the last 15 years in Spain. As you will notice, English is not my native language, so next we will show you a short video that shows the most relevant features of the Alzira model. This video has been made by Imperial College Health Partners along with Ribera Salud, and I hope it's useful for you.
The health and social care sector in northwest London is currently undertaking an ambitious project. The overarching objective is to deliver a new commissioning framework for an integrated care system to best serve 2 million people in a cost-effective and patient-focused way. Imperial College Health Partners has been exploring examples of international best practice to help health and social care leaders with the design and implementation of this significant change.
One good example of best practice originated here on the east coast of Spain. It's been titled the Alzira model. This model highlights a successful integrated care system that's overcome many challenges and problems since its creation. In this short film, we'll seek to understand more about the Alzira model and its key learnings to help inform thinking and development around the whole systems integration programme in northwest London. The Alzira model, which operates as part of the Ribera Salud Group, was born in 1999 in Valencia, when the first privately managed public hospital in Spain, the Ribera Hospital, was established. The creation of this hospital was based on 4 fundamental pillars: public ownership, public control, public financing, private management. While northwest London isn't necessarily looking to move to privately managed services, there are many learnings that can be taken from what's been built here in Spain.
Since 1999, the Alzira model has grown into a fully integrated healthcare delivery system, bringing together primary, secondary and specialist services across 5 towns here in the Valencia region. The model's been so successful that it's extended to the country's capital, Madrid, as well as transcending the Spanish border into Portugal.
Today, we're visiting 2 districts in the Valencia region where the Alzira model is operating, here in Torrevieja and in Elche Vinalopó, together with a combined population of 300,000. Serving them are just over 2,500 healthcare professionals and admin staff, 50% of whom are nurses. Specialists work across secondary and primary care settings, acting as what the Alzira model refer to as counsellors.
And importantly, primary care professionals have been given the means and tools needed to perform to a consistently high standard. Historically, this hasn't been the case. This approach, together with integrated information systems and integrated clinical processes, result in a service that is seamless for the patient and centred around their needs.
The main difference is how we organize the primary care, and the day-to-day job is exactly the same. Here at this medical center, for instance, we have the minor surgery unit. We are the referral center for minor procedures. Patients don't need to go to hospital, they come in here, and we have a computer system that make us to be in constant contact with them. We know where our patients have been, if they have been admitted to a medical unit, if they are in an emergency department. We are in real time. We know what the doctors at the hospital, how they're treating the patient.
And as all professionals and disciplines are part of the same organisation, there's an evolving culture of cohesiveness and collaboration, which really comes across strongly when talking to the clinicians working in these centres.
Es importante este sistema de incentivación porque el propio profesional ve recompensado su esfuerzo y su trabajo diario. El que más trabaja y el que más aporta, el que más implicado está, es el que más recibe.
The Alzira model is based on capitated funding, which means that the organisation is paid a fixed amount each year to provide care for an agreed population. For the 2 districts we're visiting today, the organisation receives €639 per head of population. That's to provide all levels of their care, from GP consultations to specialist services. Whilst this model of funding transfers all risk to the provider, it helpfully eradicates perverse incentives that can emerge with other funding models, encouraging collaboration, efficiency, and ultimately high-quality services.
Money follows the citizen, so for us it's critical to promote health. The healthier the citizens are, the better for everyone, for us and for the system itself.
The districts served by the Alzira model are really seeing the benefits. For example, improved patient outcomes and experiences, which we'll look at in a moment, but also increased efficiency savings of up to 35% compared to the districts in the Valencia region that aren't using a capitated funding model. Clearly, the transition to an integrated care model is very challenging, not least of all because of the sheer scale of change that has to be undertaken to achieve success. In a few moments, we'll speak to some of the people behind the Alzira model about its implementation and some of those challenges. But first, let's take a look at the results it's been producing.
As we can see, the Alzira model outperforms other local healthcare providers in areas such as average length of stay, emergency admission rates, readmission within 3 days, and patient satisfaction.
So, to explore the model in more detail, let's see what some key members of staff have to say.
The biggest challenge that we faced was cultural change, and I think that it will continue to be cultural change. It's always about people, after all.
Uno, el cambio de estructura. El otro, el cambio de mentalidad. Y, además, esos 2 cambios deben de realizarse al unísono, a la vez.
Well, we overcome that cultural challenge by defining a clear strategic plan and sharing it with our professionals and getting our professionals involved in the process. We capitalize on integrated healthcare because it makes no sense to us distinguishing between primary or hospital level. The patient is the same, the citizen is the same, the system itself is just one. So we put all our professionals working together.
Bueno, nos basamos primero en una buena selección del personal, que ese personal apoyara y conociera perfectamente lo que queríamos hacer. En segundo lugar, una comunicación muy importante, tanto dirigida al personal como a la población, que la población supiera también lo que queríamos. Y en tercer lugar, tenacidad. Problemas va a haber siempre muchos. Tendremos que ser persistentes, tenaces en conseguir lo que nos hemos propuesto.
The Alzira model has generated a fundamental change in healthcare delivery in Spain. This has resulted in improved patient experience, improved patient outcomes, improved staff satisfaction, and improved efficiency savings. However, the success of this model didn't come without its challenges. So we've learnt about some of the barriers and obstacles that the Alzira model came up against. These ranged from cultural issues such as resistance from clinical professions to the technical challenges like integrating information systems. Delivering sustainable change clearly requires a roadmap owned by engaged and committed professionals at every level. And ultimately, these professionals need to be given the tools required to make that change happen.
I hope you liked the video. It's very clear. And the journalist, I think, that says everything much better than I could probably say. Okay, so I'm just going to go over this short presentation. I have 5 more minutes, I know? Okay. Just to give you my personal point of view about what happened, because I happened to be in Alcira back in 1999, so I've been experiencing this process for the last 14 years. So first stage, when we were awarded only the hospital without primary care, from 1999 to 2003. It appears on the video. We had a lot of opposition. Nobody in Spain knew about this model, and I would even dare to say that we had no friends. We were the public enemy. Okay? But everything was ready, the legal frame was ready, the contract was signed, was clear. So our challenge as a company was to, as any other innovation, was moving from the lab to the market, was putting all this theoretical construction actually to work in a complicated environment with strong opposition from many, many stakeholders. Just as like some figures just for you to know how difficult it was, the number of negative news during the first year was terribly high. More than 1 negative news on the media every day. Second stage, after 4 years of working in the hospital and working with primary care, but in a limited way, the government of Valencia decided to expand the contract, not only in terms of duration, but also including the primary care network. So we the model entered a new stage. The challenge at that point in time was to become an integrated healthcare provider, what we now call as an accountable care organization. And the main challenge was that we had to build everything on consensus, counting on everyone, especially with the professionals and all these public servants working at the primary care level that have to be included, committed, involved in this new stage. Well, we define some main ideas as drivers for internal, external, and communication, just trying to position this new project before the different publics as something attractive to the professionals, as something which is good for the society. Well, the number of negative news started to decrease during these years. So which is the integrated model objectives? I would say that it is to do the right thing at the right moment, at the right place, by the right person, and of course at the right cost. And how we try to get it? Well, we rely on what we call the triangle for success, which is something that this is no new, but we still think that it remains actual, and it's based on clinical management, the development of our own human resource policy, and having reliable, strong, powerful, cross-functional information systems. That those information systems have to allow the professional for getting involved in the decision-making process, not only providing the professionals with clinical information, but with outcomes information as well, in terms of financial results, for satisfaction, patient satisfaction results, etc. When we defined our strategy back in 2003 to deploy and implement that integration, we defined 4 main fields of action, which were infrastructure and equipment, IT development, care strategies, and people management. Let me show you a picture. On the left-hand side, you can see the former primary care center, and on the right-hand side, that was the specialized care center, which was a subsidiary of another hospital. So they were one street apart, but they lived separated. No communication at all between primary care and specialized care. Just by doing this, we integrated both centers, and this is something, you know, there's something philosophical behind this idea, okay? We remodeled both buildings and we equipped the former PC center with X-ray, echography, and a small emergency department, not on the specialized center, but at the PC center. Okay? Just trying to make people understand that there were no longer steps, there were no longer a separation between levels. So care strategies. We faced, and I think we all continue to face, in my opinion, 2 big problems, which are clinical variability and socio-cultural, you say, inertia, reluctancy to change. So for variability, well, we've seen it before in Tony's presentation. Thank you, Tony, for mentioning us. We saw it before. Clear processes, clear algorithms, everything built on consensus again, trying to define clear goals for the organization with a holistic vision, with a holistic approach. And regarding cultural change and regarding inertia, against reluctancy to change, proactivity. We have to be proactive. We have to go and try to find the patient and citizen needs. We cannot afford waiting for the patient to come. We have to go outside and look for him, for the patient, and try to define the better solution for the citizen needs. That's what we understand, like, you know, personalized care, trying to customize a solution for every group of citizens. Well, as an example, we are now implementing a chronic plan in Torrevieja and Elche. We are running these two hospitals, and I wanted to show you this picture because it's interesting for you to know that in Torrevieja, on the left-hand side of the slide, we already have the population pyramid that will be very likely the pyramid of Spain in a few years to come. So the elderly population is on the top of the pyramid already in Torrevieja. So everything that we are doing now in Torrevieja, it's likely to become lessons for tomorrow, because we are already facing that problem in that area. Well, people management. When it comes to people management, I wouldn't like to talk only about incentives. I would like to include the incentive scheme within an entire human resource policy that includes training, includes empowerment, includes information systems, includes, of course, the incentive scheme. And as a result, we think that we have happy and committed professionals And we have been able to reach company agreements with all the trade unions in the two hospitals that we are currently running in Alicante. And information systems, what to say about the information systems? Well, this is not only about the electronic medical record. We talk about cross-functional information systems. We talk about the ERP, the human resource ERP, also integrated in a business analytics solution, including and mixing and working all the data together. So our supervisors, our middle managers, they can access all that information that relates, puts into relation the clinical outcomes with the financial outcomes and with the satisfaction outcomes, and so this is so important. And these information systems, the electronic medical record is a proprietary solution. We developed it by ourselves. These solutions allowed us for an actual integration from that former scenario, primary care, specialized care, to an actual scenario of healthcare integration. Well, finished? Okay. These are some of the features. You will have the presentation, so it's no, you could take a look at it later. And then, finally, today, why do we think that the Alcira model integrated healthcare is a timely model? Because we think that this model is still a part of the solution for the National Health Service problems. Despite some people keep saying that we are part of the problem, we think that we are part of the solution. And because we think that we cannot afford to continue to do things the same way that they have been done for 30 years. So we do need to change some things. And of course, it is easier to innovate, to bring change into the system through these models than through pre-existing publicly run hospitals. We have the ability of change things more rapidly, and we are more flexible. And finally, regarding the current situation, maybe you have heard about Madrid. Many of you have asked me about what happened in Madrid, etc. Well, we think that the model now has to work in five lines, 5 key ideas. We need our stakeholders to learn further about the model. We need people to know that public service is guaranteed at all times. We need the public to know that the PPP model makes it easier to innovate in an old-fashioned and bureaucratic system. We know that our professionals are satisfied, but we need to have them as ambassadors of the model, and we have been doing it for 15 years, so we know that we have the know-how, and we have the outcomes, so we are really confident with ourselves and with our work. Thank you.